All right, so here we are. We're going to get to the last section of this course, part 2, going over case studies. First case studies with Sarah. If you're in the clinical mastership training program where we go over live cases each month, you will recognize her in there. Now, her case is much more complicated than just hormones. She's got autoimmune issues as well, but we're going to go over some of the hormone-related principles with her case. And one of the advantages of the clinical mastership training program is that it allows you to see how all different parts of all different courses we teach kind of merge together. Because in reality, when you work with patients, you're never going to get just a hormone-related case. Like, you can have a hormone case, you can have some issues with gut issues, you can have some with infections, you can have some with, dysglycemia, diabetes, and you have to kind of manage all those things together. But to illustrate concepts of the concepts we went over in this course, we'll go over some of the highlights here with Sarah's case. And you have this document. If you want to read up about her case history, you can go ahead and do that as well. And also, the key thing with the Clinical Mastership Training Program, if you guys are involved in that program at the Crosby Institute, it's part of the 100 hours we have towards certification, which is a total of 300 hours. But in the 100 hours of the Clinical Mastership Training Program, you're actually seeing real histories, real physical exams, real patient outcomes, and we're tracking some patients now into year 2. So you get to actually see what's real. There's not a lot of fluff. It's some patients have success, some patients don't, some patients quit, some patients quit and come back. Some patients immediately get better and shocking to even myself and are out of the program, but it's real, and that's how real practice is. So Sarah, we're going to do her initial evaluation with you in this section here, but we won't have time to cover everything we've done for other conditions as well. She writes her main complaint. By the way, Sarah is 35 years old. She's a female. She's currently taking Synthroid, levothyronine. She was initially Graves' disease, went into Hashimoto's, and then she's taking some supplements, some Accutane for her skin, and you can see she's taking a bunch of different nutraceuticals and so forth. Her main complaint is cognitive function brain fog. She has low stamina and energy, constantly feeling physically depleted. And she goes on to say that I have low blood pressure and low stamina. I'm unable to build muscle and endurance through exercise, since it's so difficult for me to recover and thus stay consistent. Difficult to gain energy, quickly to lose it. So right here, we're just seeing some very clear indications of some things that apply to all the concepts we talked about. So low blood pressure, we're now suspecting the hypoglycemia type pattern, low cortisol pattern, low aldosterone pattern, unable to build muscle endurance. Inability to muscle endurance could be low testosterone. But actually what you'll see in her case is she's just overdosed on thyroid medication. So her metabolic rate's so high, she's basically burning up all her energy and developing some symptoms for it. But you have to consider all these so far. Inability to gain my healthy weight back. I'm smaller and weigh less than I did in middle school, approximately 15, 18 pounds underweight. This is a really great example of a case where being underweight is causing a lot of hormonal imbalances. Whoops. PMS symptoms began about a week ago prior to getting my period and are quite challenging to manage. Skin issues, cystic acne on face and back, eczema and skin changes. My skin tone is also much paler than my natural skin tone and does not darken when in the sun like it used to. Those are clear indications of essential fatty acid imbalances, by the way. It can fluctuate depending on my thyroid levels and other unknown factors, but still not the skin tone what it used to be and should be. My symptoms day to day, week to week are quite inconsistent, although there have been major improvements with the past year due to healing my leaky gut, just working with a functional medicine practitioner. I still have significant symptoms and concerns. I'm trading symptoms for symptoms as I try to manage my total health. I want to achieve optimal health before my husband and I start having kids in the next 2 years. I've been battling my health and struggling immensely for the past 16 years. Just want my quality of life back so I can begin working consistently again and living the life I want to and deserve. I want to be the best person I can be myself, my husband, family, friends, and future clients' career. So she did have an autoimmune response. She did have Graves' disease. She got that treated. She got Hashimoto's. Now let's look at the things we just talked about and the course itself. This is her metabolic assessment form. Okay. Now, on the metabolic assessment form, you'll see she wrote down her chief complaints again, just like we went over. Cognitive function, PMS symptoms, and so forth. And category 1 is symptoms of dysbiosis, not really much there. Category 2 is leaky gut. She's been working on that with a functional medicine practitioner, not much there. These category 3 is loss of tolerance, not much there. Belching, burping, these are hypochlorhydria, not too much there. Category 5 are symptoms associated with gastric ulcer, not much there. Pancreatic enzyme deficiencies, that seems okay, not much there. Some abdominal distension and bloating, but this is a section for SIBO. We don't really see clear SIBO patterns there. Here we see some issues with unexplained skinny itch, but not really all the symptoms we would associate with the gallbladder section in that area. Category 9 are symptoms associated with hepatic biotransformation. We see a couple of 3s on here, but they just could be acne and skin related. We don't see a whole cluster of symptoms to really suspect hepatic biotransformation imbalance. So usually when we look at these forms, you want to see like all these symptoms kind of clustered together to really suspect it. Now here we do see lots of 3s and 2s and 1s, and these are all the symptoms of hypoglycemia. We're not shocked because it seems like she's in the low cortisol, low blood pressure, low BMI pattern. And then if we go on to the next page, you can see that she has some dizziness when standing up quickly. These are all signs of like low cortisol function throughout the day. So the low cortisol hypoglycemic pattern, not really much high cortisol patterns. She's got a little bit of symptoms associated with electrolyte imbalances potentially, not that clear. Tired, sluggish is her main complaint. She's on thyroid replacement. Out of her third of her eyebrow is thinning. It's common with thyroid patients. And nothing really significant there. And then you can see a lot of her menstrual cycle symptoms here. Pain and cramping during periods. She puts 3, which is pretty severe. Heavy blood flow. Breast pain and swelling in development. Acne. So lots of PMS symptoms that you can see in that area there. And then she writes down, like when we look at essential fatty acids, which is important for us, how many times do you eat fish per week? 0 to 2. And then how many times do you eat raw nuts or seeds? 5 to 6. So she is getting some fatty acids in her diet. That's pretty important. And she's not able to work out at this point, it seems like, 0 to 2. And then if you look at her 3 healthiest foods, the 3 worst foods she writes down is beef. So she's considering beef unhealthy, which may not be good with someone who's underweight. That might be something we need to change with her when you look at that. Tostito chips, we agree with that. Fries. And then her healthy foods, broccoli, kale, lamb, chicken. And then, she's on various supplements and medications. She also writes down she's taking selenium, magnesium, vitamin C, methylfolate, some female hormone balancing kit with adrenal support, saw Palmetto Plus, some kind of protocol there. The online protocol looks like. Gut healing, megaspore, glutamine, coconut oil. Okay. This is the initial interview we did for the clinical master program about her case.
Hi, my name is Sarah. I am from the United States, and I'm here today to see Dr. Karazian to address some ongoing issues that I've been having with my original diagnosis of Graves' disease and then later Hashimoto's. Those symptoms are related to low weight, brain fog, as well as very low energy. And I look forward to addressing and hopefully finding the root cause today and finding the best path forward so that I can have my quality of life back. I have addressed better eating, so I have a low inflammatory diet. I've worked with functional medicine doctor as well as an excellent endocrinologist who has also gone above and beyond in his realm to kind of help identify possible root causes. I've also worked with a nutritionist which helped heal leaky gut, which was really the foundation to my healing. So I think basically what I would define as success is just feeling better and having any improvements really from what I've been trying to deal with myself. I've educated myself as much as possible. I've worked with great specialists, great doctors, and I've only been able to get so far. So my expectation today is to really get as far as we possibly can with trying to identify anything that has been maybe misdiagnosed, or really just trying to get to the root cause and then finding really the best path forward, whether that's changing my diet again, whether that's eliminating any type of supplements that I've been taking, maybe replacing it with something better. I think that success to me is really just having my quality of life back, really being able to gain more energy, gain my weight back, just having even my mental stamina back in place so I can build from that and become stronger mentally and physically. And I think a realistic time frame can be anywhere from maybe 6 months to 1 year. I think 6 months to see maybe some results, maybe up to a year to kind of have more complete healing, especially when it comes to inflammation.
Okay. I'm going to go over some of her previous lab tests, but you have all of her previous lab tests in this file, which is her case study. And let's go over some of the things that were more like hormone related. So here's some of this stuff we've seen in her past record here. Here's the chemistry, a metabolic profile. We talked about looking at these as just a way to rule out any kind of serious diseases. So we don't see anything going on with BUN, creatinine, sodium, potassium, electrolytes, bilirubin. So, no signs of anything too serious there. Then when we look at this profile here, you can see that her serum vitamin B12 and folate are high. That's going to happen anytime somebody is taking any kind of supplemental B12 and folate. That's going to raise serum levels, so that's not really a big concern to us. Total cortisol in the AM seems to be elevated here. And, serum total cortisol AM being elevated is something that is a red flag. We got to see what's happening here. This could be, sometimes it's just cortisone anti-inflammatory cream. And if you notice, she's got some inflammatory skin conditions. So this may possibly just be that, because she doesn't have any symptoms of low cortisol, okay? And then we can look through here. We can look through her thyroid panel. She's on thyroid replacement. She's being managed by an endocrinologist. And one of the problems that's in her case that just I can tell you working over the past year and a half with her is she keeps associating every symptom she may have as being a thyroid issue. So she's been very reluctant to reduce her thyroid medication. But it really is impacting her. She's really impacted her ability to gain any weight. So one of the things that we had to do in her case was really discuss, you may be taking way too much thyroid hormones. And, as you're working with your endocrinologist, you may need to back off as needed and not be so resistant against doing something like that. Anyways, we don't see any major hormonal shift with the blood test. If you look over here, this is her testosterone level. And whenever you're looking at these serum levels of hormones with a patient that still has menstrual cycles, you have to remember what phase of the cycle they're in, luteal phase or mid-cycle or so forth. With her levels, we don't see anything with any of these hormones that are totally abnormal. And then in her file, she also already had a urinary profile done. So you can see her sex hormone levels throughout the day. And as we take a look here, you can see on a urinary test, she's got low progesterone metabolites below the reference range. And if you look a lot of her her estrogen metabolites, like estrone, E1 is low end of the luteal range, E3 is low end of the luteal range, methoxyestradiol is in the low end of the luteal range, total testosterone is within range, low end of the range here, low end of the range here. And you can see she's not, some of these metabolite levels are low. And it would be very easy to go, oh, well, let's just give her estrogen replacement therapy. But do you really want to give a 35-year-old female estrogen replacement therapy who wants to have kids in the future? Do you really want to throw off the pituitary ovarian feedback loop? The whole goal of her is to try to get healthy so she can have a healthy pregnancy. So the concept of just putting her on hormone replacement therapy is not even really an option here. And, what are the underlying factors why our hormone levels may be low in the first place? So we can look over here. Now we can see with the urine testing, which is different than the serum test in the past, her cortisol levels are low. This is urinary cortisol, low end of the range for waking, afternoon, nighttime. This is realistically more we would expect with her. And then, with just the typical things you see with urine, some of the metabolites high on the high end of the range, other ones in the low end of the range. you'll see those patterns. So for the most part, most of the things you're seeing on this urinary test are having your hormone levels on the low end of the different reference ranges. Okay. And then they have a nice graph, and these are neurotransmitter levels, which are all within range, but they don't really have any clinical significance. And then you can see that the practitioner she was working with checked her for adrenal antibodies, which was very smart, just to make sure she didn't have any underlying reasons why her cortisol levels are always low. And IGF-1 levels are measured within normal index numbers. And then the free androgen indexes were checked, total testosterone, free androgen. These would look for things like PCOS patterns if they were abnormal. Those were within normal limits. Serum creatinine just slightly low, 46. That really doesn't mean anything by itself, with the other laboratory markers all intact. And then you don't really see any significant changes in our serum profiles with the reproductive hormones, LH, FSH, estradiol. And this is a great example of like urine versus serum. And some people look at this and go, oh, urinary testing doesn't work, it's inaccurate, it's all made up, it's all inaccurate. And then the person that does urine testing will look at serum and go, see how bad serum is? Serum doesn't catch anything. So people have their biases, but in reality, you're going to see these things with hormone profiles. You have to just realize it's the way it is. You have to use a tool. The key thing is use the same tool that you want with the patient, with the same lab, and then see if things are changing and try to correlate things with symptoms. Now, obviously, these weren't done in the exact same dates, so that could be a factor too. But the problem with serum testing with a lot of these reproductive hormones, especially female hormones, is they're so broad, and the saliva and urine ones seem to be more functional with people that have mild imbalances. But serum testing can be very reliable for men's testosterone levels. Now, that's your past lab work. So when we're really looking at, all we're really seeing is no underlying severe metabolic disease. We know she has a past history of Graves' Hashimoto's. Her urinary tests show some low-end levels of estrogen, progesterone, low levels of cortisol. Her blood tests don't really show anything that's really significant. So not too much from the hormones there. Okay. Then her main complaint was cognitive impairment. So I had her fill out a Montreal cognitive assessment form. This is a standardized form to look to identify mild cognitive impairment. So let's go through that. So one of the first things we did with Sarah is have her fill out a Montreal cognitive assessment form. If you remember from her chief complaints, her number one chief complaint is impaired cognitive function, as well as low stamina and energy. Now, anytime you see a 35-year-old with significant cognitive function decline, we need to be a little bit concerned. So just to get an idea of where she's at, we had her fill out the cognitive assessment form, the Montreal cognitive assessment form. And you can see that her score is 26 out of 30. And if you remember, normal is above 26. So she's right on the border of meeting the criteria for mild cognitive impairment. Okay, this is not good. You do not want a 35-year-old with a score of 26. This is a really, really bad sign. And then, when I saw this, I'm like, okay, am I dealing with the early Parkinson's disease here? So early onset Parkinson's happens at age 35. Is she starting to have alpha-synuclein in her brain? Does she have some severe brain injury she didn't know about? So we don't have time in this part of the actual case evaluation in the clinical master program. You'll see the whole workup with this very, very, very thorough neurological exam. She has no signs of any of those conditions or diseases. This is most likely just her blood sugar hormonal system messing up her brain, but no signs of actual disease or pathology. But her score being so bad is a so one of the first things is a concern. So let's look at this part of her blood pressure. Now remember, she's underweight. She has symptoms of low cortisol. So we immediately would start to suspect her blood pressure may be low. She may have low perfusion because her blood pressure is low. So let's go through that. So her seated blood pressure, after seeing in that position for 3 minutes and having in a resting state, is 100/67. So we'd like to see, obviously, blood pressure in the 120/80 range. She's on the lower side. Now you have to remember she's underweight. Remember, body fat helps release adipokines, and adipokines have modulating effects on neuroendocrine immune function. And when you have low blood pressure like this, with a history of reduced energy and stamina, you have to consider the fact that there's lack of perfusion and blood flow going to the brain. That could be one of the reasons why her cognitive impairments may be there. So as we look to find physiological mechanisms that may be impacting her chief complaint, which is cognitive impairment, seeing blood pressure in the 167 in combination with her symptoms of hypoglycemia already means that her brain may not be getting enough oxygen. And remember, perfusion from blood pressure is also necessary to carry hormones and other nutrients necessary for mitochondrial function. So that, with low blood sugar, being underweight, may all be contributing to her cognitive impairment. Now, when she stands up, her blood pressure does go up 121/70, which is a really good sign, which means that she has some integrity in her autonomic and catecholamine systems to regulate her blood pressure. And we don't see any history of patterns of orthostatic hypotension and any dizziness when she stands up, which are all good signs. Yeah, so her blood pressure wasn't that bad, but it was low. We want to get that improved. That'll help with the perfusion. We want to do some things to improve her chief cognitive impairment. But these are like adrenal gland functions. So, when you look at her history, you see symptoms of chronic hypoglycemia. Like once her hypoglycemia can get stabilized with her diet and lifestyle, obviously she is highly motivated and is doing everything she needs to from advice she's been given. She's highly compliant. But she may not know, like she has to do a better job stabilizing her blood sugar levels. That can really make an impact on getting her adrenal glands to function better. That can raise aldosterone levels. That can get her blood pressure back to normal, closer to a normal reference range. That can help with perfusion. So those are things that we're immediately starting to pick up on. Now, if you look at her on the BMI, she's definitely in the body mass deficit area. And this is, and they create a real life example of this slide we showed over and over again throughout the course, which is how adipokines have a strong influence on regulating gonadotropins and FSH and LH and insulin cycling and immune regulation and so forth. Now, you guys remember, the goal here isn't to make her feel good all of a sudden. If you want to make her feel good all of a sudden, just put on a bunch of hormones. The goal for her is to have a healthy, functioning endocrine system so she can have a healthy child. So if you put a 35-year-old immediately on hormones and become the hero, now they feel great. What's going to happen when they actually want to have kids and now their feedback loops are not optimized and you haven't really addressed the underlying condition, right? So that's the reality of these kind of cases. They need the underlying mechanism addressed. Now, right here, we know she has deficits here. She doesn't have enough adipose tissue that's healthy for her. Okay, and part of that is, she had a hyperactive thyroid disease. Her metabolic rate was really, really high. She doesn't be able to rebuild that muscle mass, and she's potentially still on too much thyroid hormones. Okay, let's go here. Just looking at her surface skin temperature, looking for vasomotor function. It's like a 17-degree difference.
Wow. Really?
Wow. Can you see? They were up here.
See, what's so strange is that I get so physically uncomfortable with regulating my body temperature.
Wow. It's bad circulation. Okay. And then you blue here. That's
funny, not funny.
I know.
It's pale and white. Should be pink.
Should be pink like my hand?
Look at that. See how nice that looks? It's like zombie nails. So her peripheral temperature and circulation evaluation identifies a few things. First of all, there's definitely some poor circulation, poor blood flow, and even potential vasomotor imbalances. And vasomotor imbalances can sometimes occur with people that have thyroid dysfunction that's not being treated, or in her case, it just may be the fact that she's taking a lot of thyroid hormone. She's taking not only T4 but T3 and at very high levels, and she could have a combination of thyroid resistance having an impact on that. So there's probably some influence of her thyroid medication, her underlying thyroid condition, and her lower blood pressure and some perfusion index issues all potentially playing a role. You can see in the upper extremity it wasn't as bad. It was only a 10-degree difference, which it was within the normal borderline areas. And then if you look in the lower extremity, you can see that her blood pressure, her surface temperature goes from like 89 to 6 to almost 69, 17 to 20 degree difference depending on when we test. And then if you look at her nail beds, you can see that cyanosis in her toenails, and just touching her feet, it was just like they were frozen. So we definitely see some issues here related to circulation and blood flow. Now, circulation and blood flow could have a significant impact on cognitive function because you have to, get proper, regular, healthy blood flow to the brain. So just like her toes are freezing and cold and have some cyanosis, those types of mechanisms can also take place in the brain. The brain is also very peripheral, just like the feet, but it's also vertical. So it's very prone to having hypoxia-related events that may be impacting her general brain function as well. Now I think her vasomotor tone is going to be a combination of trying to get her thyroid hormones balanced, trying to get her blood sugar balanced, trying to get her perfusion index improved, trying to get her hypoglycemia, adrenal function all under control. So it's going to take a little bit of time, but it's definitely something.
Yeah, so you can see the dynamics here. Now, in the course it shows you some slides of like, here's hypoglycemia exam findings, like thinning hair because they're not getting blood flow to their scalp, just like she's not getting blood flow to her brain. You'll see some like poor circulation, poor nail function, cold hand, cold feet, poor capillary refill time, and then like low end of normal blood pressure. All the things that we talked about in the exam section of the course for hypoglycemia, she's got them. Okay. And then if we look at her skin here with some, during the exam, we can see a few things here too.
So the Accutane took care of any of your skin reactions?
Oh yeah, all my acne.
You were getting any redness? You have a little bit of redness
Tiny bit, yeah.
up there. Is that more than usual?
Mm-mm.
Okay.
It's the same. I'm only getting like tiny little bits of acne around here. But I don't know if that's the food, relative to food.
So when I look around the skin around her arms and face, you can see that she has a little bit of cystic acne around her lips. And cystic acne is really an inflammatory form of acne that's caused by inflammation. And then she's got a little bit of atopic dermatitis or eczema around her forehead, upper eye area. And I use a magnifying glass to look at these things. So it's not as clear in the camera, but it was much more clear in person. Now, if you are evaluating the skin into your patients, it's always great to have a little magnifying glass. You can really see things a lot better. So what we can see with her is that she's got some inflammatory reactions of cystic acne and eczema, which is a reflection of her immune system, right? The skin is a great window of what's happening with the immune system, and so we see some systemic inflammatory responses in her skin.
Okay, let's go on to some other parts of her skin.
The Accutane took.
Now remember, here's the thing. We're worried about prostaglandin imbalances, and so far we're seeing when you have an inflammatory skin condition, you're going to burn up your prostaglandins. Just the inflammation itself is going to use up all those fatty acids really quickly. She has an underlying autoimmune inflammatory condition, so she might be burning up her prostaglandins. When you burn up your prostaglandins, you only have so much you make for your food and diet per day. You don't have the ability to modulate them for the endocrine system. So we're immediately thinking we need to increase her prostaglandin dose just from some of the things we're seeing with her skin.
Any of your skin reactions?
Oh yeah.
Let's go to this one here.
Now let me get John. Can you look at this here? Your skin is really red. Mm-hmm. We can kind of put our finger impressions on it. So we're going to check your histamine levels.
Okay.
So when we examine her skin, we can see that she has some skin blanching and she has some xerodermia or dry skin. Now, the blanching may be related to vasomotor tone imbalances, may be related to high histamines, and may be related to liver disease. Now, liver disease is unlikely because with her past medical history in her labs, there was no indications that there's any problems there. Her transaminase enzymes, her laboratory markers that would be associated with liver disease, like albumin, globulin, SGOT, SGPT, GGTP, they're all within normal reference ranges. And it's possible that she may have some vasomotor tone issues just because she's trying to balance out her thyroid hormones and she's taking a lot. And as you start to reduce your dosage, which she's trying to do with her endocrinologist, you could have periods of time where you have too much thyroid hormones, you back off, and then you get a little bit of thyroid resistance with a period of time where there's not enough thyroid hormone receptors, and then that can throw off
the amount of thyroid hormones that your tissues need, so you can get some vasomotor tone issues, which is still possible with her, and that can be a reason why she's having some skin blanching as well. Okay, so these are some of the things that highlighted over the examination findings we see from hormone-related patterns, and then the key thing with her is here's the impressions of her case so far. So I put in here, Sarah suffers from Graves' disease, which has been managed with radioactive iodine therapy. She's currently on thyroid hormones, working with an endocrinologist to reduce and eventually eliminate her T3 medication. She needs to be on T4, but she's taking in this excess T3 because she's worried about her symptoms being related to not having enough T3 in her system. But this increased T3 in her system is really causing her metabolic rate to go up, so we have really no chance to increase her body weight right now. Anyways, she'll go on to stay on her T4 replacement. It is possible she has been prescribed excess thyroid hormones that have a significant impact on her metabolic rate and have contributed to her becoming underweight. Her body mass index and waist to hip ratio indicate that she is underweight. Her current weight is 99 pounds, and her normal body weight should be 115 to 120 pounds. She also has patterns of hypoglycemia and hypotension. Her perfusion index is low at 0.62. She exhibits poor patterns of circulation with a 17-degree difference of temperature between her thighs and her toes. She also exhibits cyanotic and pallid toenails, which you guys are able to see in the video. Sarah's dietary evaluation indicates she is not consuming enough saturated, unsaturated fat, and her diet is deficient in essential fatty acids. She also has extended periods of time-restricted feeding between dinner and breakfast. The combination of excess thyroid hormone exposure, extended periods of time-restricted feeding, patterns of hypoglycemia, and reduced body fat may be playing a central role in her chief complaints of having low stamina and energy. These patterns, in combination with her lack of essential fatty acids in her diet, may also play a role in her current PMS symptoms and inflammatory reactions of her skin. So everything we've been talking about in this course. During the examination, there were notable patterns of atopic dermatitis, eczema, dermatographia, hyperalgesia, and a positive blanch test that occurs with elevated levels of circulating histamines and IgE allergen responses. Identification of these potential dietary and environmental allergens will need to be evaluated. That's just a different part of her case. Sarah's primary concern of impaired cognitive function appears to be due to a combination of factors that impact her cerebral endurance. They include hypoglycemia, hypotension with reduced tissue perfusion and poor circulation. She does not appear to have symptoms associated with neuroinflammation and brain fog, unless she's exposed to dietary triggers such as lectins or pepper flakes. There's also the possibility of autoimmunity to neurological target proteins, and specifically to the cerebellum. She reports specific symptoms of dizziness and vertigo, clumsiness in the brain fog when she's exposed to dietary protein triggers. During these autoimmune reactions, in addition to her neurological symptoms, she complains of systemic body pain in her muscles and joints. These findings may be associated with muscle and joint autoimmune reactivities. Sarah has been able to reduce her symptoms following dietary restrictions of an autoimmune paleo diet. Further evaluation determined if she was diagnosed appropriately with pernicious anemia, and also needs to be confirmed by evaluating intrinsic factor blocking antibodies. And she wasn't diagnosed with intrinsic factor pernicious anemia properly, by the way. And we did get testing back on her. She did have neurological autoimmunity. Many people with Graves and Hashimoto's have thyroid and neurological autoimmunity. She had both. So now we're dealing with the concepts of hormone imbalance. How are we going to get her endocrine system healthy enough to have her to the point where she can reproduce a healthy child? And how do we get her blood sugar adrenal system functioning back while overlapping with autoimmunity? That's real life. That's how it is. You go to a seminar, you go, information, and then you get a real patient. It's like, well, there's all these other variables involved. That's why we have the clinical mastership program, to show you real cases and how you have to kind of learn to massage some concepts into each other. Now, the laboratory recommendations, we did in array 5, and that's where we found the neurological autoimmunity. But a blood chemistry panel, we an updated one. Nothing other than the functional hypoglycemia that was significant. Her histamine levels and IgE allergens were fine. We did no additional special studies at the time. So the dietary recommendation was continue with the diet free of gluten, dairy, nightshades, and lectins, because we got to follow the autoimmunity part of this. Eat diverse fats to improve prostaglandin balance. Use oils such as flaxseed oil, cold-pressed organic, rapeseed oil, avocado oil, borage oil, evening primrose oil, fish oils. Stabilize blood sugar levels. Eat within the first hour in the morning with a high-fat, high-protein meal. eat every 2-3 hours with healthy fats, proteins, and high fiber foods. Increase sodium intake, salt foods regularly using sea salt, not iodized salt. And then nutritional recommendations. So I put it on a product called Adrena Stem, which is a glycyrrhiza topical cream. Glycyrrhiza is a compound from licorice that has an inhibitory effect in 11-beta-hydroxysteroid dehydrogenase and allows cortisol to not be metabolized and cleared out as quickly. So people have low cortisol, helps keep their cortisol levels higher. It also helps get their aldosterone levels up to help with blood pressure. I put on a product called Proglyco SP, which is basically the nutraceuticals you would use to support adrenal gland functions, lots of B vitamins and lots of adrenal support kind of botanicals. And then I put her on a product called Electro pH Complex, which is things like potassium bicarbonate, and there's some electrolytes to just support her. She was having some electrolyte imbalance symptoms. She was instructed to continue with any other supplement she thought that was helping her feel better. I didn't want to restrict that from her. She was dealing with, she was already on some stuff for leaky gut that she felt was helping her. I'm like, if that's feel like it's helping you, go ahead and do it. So then we had goals of clinical management: stabilize blood sugar levels and prostaglandins, increase body weight from 115 to 120, and continue to investigate autoimmune triggers, and then prenatal support over a period of time. So the phase 1 of our care was to evaluate, since pregnancy is a concern for her, evaluate follicle integrity in an anti-Mullerian AMH test, ultrasound follicle reserves, and plan strategy for pregnancy timelines. So one of the things after the workup was like, I don't know how far along you are with your ability to have a child. Let's get your fertility testing done. Go see your OBGYN. Go get an AMH test. Go get an ultrasound. And those all came back healthy. Okay, so now we have time. Like, let's get you as healthy as possible now. Evaluate her autoimmunity with Saxray-5. She did have she did have neurological autoantibodies, but not a intrinsic factor. Continue working with her endocrinologist to just get her off the T3 or just work on T4. Stabilize blood sugar levels. Increase body weight from 99 pounds. She's underweight to a normal body weight of 115 to 120. Increase dietary fat diversity for prostaglandins. Flaxseed oil, virgin olive oil, cold pressed oil, organic rapeseed, avocado, even primrose oil. That's all phase 1. And then phase 2 is really to evaluate her for chemical immune reactivities and things that can impact healthy pregnancy and autoimmune triggers. And then she was told to email me regularly and tell me about her body weight, her blood pressure, symptoms of hypoglycemia, if she has any drops, if she has no appetite in the morning, or have drops in energy levels in the afternoon, or she has sugar cravings, and she has an improved function after meals. Those are all clues that she's not stabilizing her blood sugar well. Any PMS symptoms, any brain and physical endurance symptoms. And if you kind of look at what we did the sheet I gave you, like diet-wise, get enough protein, get enough fat, saturated, unsaturated fat, stabilize your blood sugar levels. We followed all the guidelines here for diet. And then for lifestyle, we're trying to get her underweight patterns under control. Like, this is like real life example of the sheet I put on the slide. Like, this is stuff we actually really do with patients. It's not just theoretical, okay? So this is her more recent, her 17-month, let me show you her 17-month outcome. This is the most recent follow-up I did with her. I think it was a month ago. This is her initial metabolic assessment form. You can see all the 3s and 2s and symptoms here. And this is how she is now. Almost everything 0. Almost all her symptoms are gone. Okay? This is the follow-up questionnaire I always use when I follow a patient. Yeah, this is August. Okay. So, since your last appointment, which parts of your treatment protocol have you followed? I weigh myself all throughout the day and have kept record of my weight, which is increasing. Yay. I salt all my food, add fatty oils, and or vegan butter and mayo to increase fats. Snacking regularly with high fat and proteins. I continue to uphold a strict diet of no gluten, no dairy, no nightshades. I still don't eat pork products. It gives her headaches for some reason. Which part of your treatment protocols have you not followed? I've not taken my blood pressure as regularly as I should. I do, however, know my average baseline on what I do take my blood pressure. Do you have any new persistent symptoms? No new persistent symptoms. I feel great. Just really want to get to 115. What are your current concerns? Her concerns are like bad breath. That's one of the things. Here's the video follow-up we did just in August. Okay, so I got your follow-up document. Let me pull it up here. So it looks like you're doing really good.
Yes. Yes.
So let's go through. Okay, you can see the screen?
Yep.
Okay. So since your last appointment, went through the day, kept record, which is increasing, yay. That's fantastic. Saw all my food and had fatty oils. Wonderful. Vegan fatty oil, increased fats. Snacking regularly with high fat proteins, perfect. Continue to uphold with strict day of no gluten, dairies, nightshades, perfect. Now with your diet, are you having any energy fluctuations or no?
No, actually, I've been feeling really good, especially since I started taking the anacetyl.
And acetylcysteine? Perfect.
Yeah. And I noticed that I didn't have to, I don't know if it was on this form, because I was just having issues with making some of the updates, but one of the changes was that I just don't feel the heavy abdominal cramping that I was feeling, and I don't have to rely on the Imodium as much. So that's becoming less. Yeah, now I'm just kind of taking it just as a precaution, but I haven't had any flare-ups, knock on wood.
Yeah. So remember last time we did a follow-up where your glyphosate levels are high, and then suggest you take the 1,500 milligrams of NAC just to support clearance of chemicals and specifically glyphosates because they go through that glutathione pathway. You probably want to take that indefinitely all the way through your prenatal care and into your pregnancy.
Okay.
It's not something that has any adverse effects. It's just an amino acid, so it's not like you'd be worried about it even if you were pregnant, of any adverse issues or.
I can just keep taking this.
Yeah, the NAC, and we'll go over your chemical reactivity panel. Your updated.
I'm sorry, you said up to 1,500 milligrams?
Yeah,
It's still safe even through pregnancy.
1,500 milligrams twice a day, which is like 3,000 milligrams. Yeah, it's sulfur amino acid, and it's not like a botanical that pushes a lot of different pathways. It just provides the sulfur amino acid structure, so your liver pathways can make glutathione, and also to support something called sulfation, which is sulfur binding to toxic chemicals, so it can become water soluble, so you can eliminate it. So you can take that. You should take that, for at least a while, and it's not bad to do. Okay, and then the other thing we talked about also last time, since we're on this topic, was also you were going to try to work on some muscle mass building and exercise. Were you able to do any of that?
Yes, I have not, but only because we've just had a lot of changes in the logistics over the summer, and so our schedules were just a little bit crazy. But that is going to change. So I'm just getting over a really, really bad head cold that's laid us out this week. But I'm taking that very seriously to start weightlifting. But the reason I hadn't was just because the schedule was wonky, and at that point I was just making sure that I stayed consistent on my snacks. Okay. And sleep and all that stuff, yeah.
Okay. Perfect. I've not been taking blood pressure regularly. That's okay, as I should. I do, however, have my average based on when I do take my blood pressure. So what is your blood pressure running now?
I had it written down.
Okay.
It hadn't changed from the last time. I think it was like 90s. Oh gosh, 96. It's in the higher 90s.
Okay.
But I'm not really passing the 100 mark on the whatever the first on the upper, yeah.
Okay, no problem. Just every now and then check it, just at some point. As your weight increases, your blood sugar gets more stable. Your adrenal glands should get healthier.
Right.
As your adrenal glands get healthier, they should be able to retain more sodium, and your blood pressure shouldn't drop as much. There's a pathway with aldosterone that controls sodium regulation, but it can take some time to rebuild. And everything else is good there. Okay, so great field rate. Just really want to get to 115, 18 pounds soon. Great. So you're on your way. You're doing all the right things. You figured out how to eat without having energy roller coaster rides. So you got your snacks figured out. Okay.
Okay, this is, but the key thing is what I want you to understand with this case is like all the concepts we talked about, like low blood sugar, low body mass index, all these things, this is how they apply to real life patients. They're all very translatable. It takes time to get systems back. Now, if you were to take a patient like Sarah, like first of all, you have to understand she's working with one of the top, most qualified endocrinologists out there. They don't know what to do for her hormones or infertility because they're looking at it from a very disease point state. So working with a functional medicine practitioner and like, okay, you got autoimmune, we're going to fix your leaky gut. And they were kind of like, just wondering what to do from there.
And this is these basic simple concepts we talk about that the endocrine system needs to function is typically what's overlooked in the healthcare. And the trap with a patient like her is to go, oh my gosh, all these hormones are low. She needs to be taking all these supplements and all these herbs to get these back, and that's not the factor. So you want to understand, these key priorities that we've been going over with the course. The other thing with Sarah is she's in complete autoimmune remission. She hasn't had any autoimmune flare-ups since she's been following the guidelines we're giving her. So she's on her way to having a healthy baby soon. Okay. Now let's go over case number 2. This is a 16-year-old with low progesterone and mild PMS symptoms. So let's get the 16-year-old on hormone replacement, please. No, I'm just joking, but that's what happens. Okay. So this is a patient you guys have seen before. She was one of the cases in the Hashimoto's course, Francesca. If you remember, she had autoimmune disease, and as we worked her up, we found out she had kinetic tremor and cerebellar disease and ataxia, and she had cerebellum autoantibodies in combination with the thyroid condition, and her autoimmunity since 3 years ago when we first did Hashimoto's workup and course, and you got to see all that, has been in complete remission since. But we get a panic phone call, hey, from parents saying her progesterone levels are low, she's about to start college, is this going to be a problem for her hormones? What do we need to do? We're afraid that this might flare up her autoimmune disease. We're doing so good to make sure she stays in remission, and we want to make sure she's as healthy as possible before she goes to college. I go, okay, that's understandable. And by the way, she got into Stanford, which is very impressive. Okay, so she's followed the protocols, take all the recommended supplements. She's been doing everything. She's not had any flare-ups. Sometimes she just gets some random headaches, but she had some routine lab work done. So once I got her stable from autoimmunity, I wasn't managing her case anymore. I said, just have someone manage your hormone replacement therapy. Call me if you need anything. And so we get this call 3 years later. And one of the concerns was her progesterone levels were 0.6, and they should be, in the luteal phase, it should be at least 2.6 to 21.5. So there was some concerns for, why is her progesterone level low? And I'm like, this is a spot test. This is just measuring your hormones in a very one-time area, but you have menstrual cycles. So let's see what's happening with your menstrual cycles. So I had her complete a 30-day saliva test, where every 3 to 4 days she was collecting saliva samples. And then we can actually measure out her hormones throughout her menstrual cycle, actually see if she has any issues. Because I also want to make sure as she goes into college, she doesn't have any underlying hormonal issue and flare-ups, and then all of a sudden she's going to have her autoimmunity flare-up, and then that's going to impact her college career. Like, this could be serious. So endocrine imbalances can absolutely trigger relapses of autoimmune disease. So here we can see her levels of estradiol and progesterone. Now, if you look at these, what you'll notice is she's got an abnormal cycle. Now, you can see these two arches here. Now, let me show you something. This is how it should look. The first half of the cycle, estradiol should be high. Right before mid-cycle, you should have an estradiol peak, and then progesterone should be high. Now with her, you don't see that. It looks like you're seeing that, but that's not what's happening. What you're seeing is that her progesterone is up in the first half of her cycle, and her estradiol is up in the second half, like a switched pattern. This is a follicular and luteal phase deficit, okay? So we see that, then we see her, we don't see any major changes in testosterone, but this is an average. But you immediately would suspect PCOS with this. PCOS can definitely cause that. And then if you look at her FSH levels are low. She's not putting out proper follicle stimulating hormone, probably why she's not getting that estradiol peak in the right timing. Her LH levels are fine. I'm like, okay, well, you definitely have some pituitary dysfunctional dysregulation that's causing your hormonal issues. I mean, if you take any kind of hormones, you're going to make things worse. So you got to figure out what's going on. So she had some other lab work done. She was waiting to get back from a practitioner she was working with, and boom, here it is. This is a saliva test, I believe, yep. And look at her serum testosterone, 7.070. Way outside the lab range. Here's her cortisol, way outside the lab range. This is like a PCOS pattern. And here you can also see like her progesterone levels are low, her saliva progesterone's low. But look at her testosterone. So this is how PCOS shows up. It just pops up here on labs and here and there. And it turns out during this whole process, she was so stressed out about colleges and it applied to like 30 different universities and was so overwhelmed with everything. Her stress response got really, really high. And she like progressed into this PCOS cortisol type pattern. So, and if you look at some of her lab tests that we got from previous practitioner, look at her insulin level spiked up. That's not normal. That's 21.5. Insulin resistance score. So she developed a stress-induced PCOS type pattern. Nobody knows she's got Hashimoto's. She still has the antibodies and her T4 levels. And then her fatty acid ratios, she's low in omega-6, low in arachidonic acid. So she's got to eat healthier fats. Fatty, some more egg yolks, and then healthy butters and fats and so forth. So your typical hyperandrogenism. She is this slide. This is the slide we talk about with PCOS, and then it throws off pituitary gonadal axes, and that's what she has. So we're like, listen, please do not go on progesterone therapy. Please don't go on any hormones. We don't want your feedback loop dysregulated any further. Let's just calm down your stress response as things are calming down as you're not there in application, and just focus on stabilizing your blood sugar levels. And as she started doing that, it really made some big improvements in overall health, and we didn't get into the trap of just seeing low progesterone level and having to jump right into some kind of hormone replacement therapy. And I'm really glad the parents connected with me to go over that. Now, she's being managed phenomenally by a functional medicine practitioner right now, so she's very lucky. But this was, just one of the things that we needed to get a second opinion on. Okay, let me show you another case here. This is a 49-year-old male. 49-year-old male, chief complaints, muscle tightness and pain all throughout his body, inability to recover from exercise, mental and physical fatigue, low libido, depression, loss of motivation. This is the aging male symptom questionnaire, directly related to low testosterone, and he is definitely abnormal. He's got 5s and 4s all over the place. This is all very clear numbers and patterns of low testosterone. So he's in the clear abnormal pattern for those based on this questionnaire symptom. If you look at our blood work, glucose is high, 101. His ferritin is high. This is from inflammation. He's got some of the metabolic syndrome PCOS pattern. His homocysteine is high, LDL is high, HDL is high. So this is like a classical metabolic syndrome pattern, and he's had this for a while. He's doing intermittent fasting. He's taking a lot of insulin supplements. He's doing exercise every day. He's doing all the right things, but his numbers aren't really changing that much. You can see like his HbA1c was 5.4 after doing intermittent fasting and training every day, working out with a trainer, and lowering his carbohydrate intake to like a carnivore diet. His HbA1c is not changing much, and his lipid profile is not changing much. So he's like, okay, listen, I don't know what to do. I can't push this anymore. I don't know what else to do besides taking every single supplement, exercising, working with the trainer, and cutting down my carbs to almost nothing. Like, okay, well, you got these low androgen patterns. You can look into, let's get your testosterone levels measured. Let's make sure you don't have any forms of andropause. Or we could try some peptides and see if that improves your insulin patterns. So he's like, yeah, I want to try peptides first. I don't want to do hormones. So this is a lab test before sermorelin. So sermorelin is, as you guys know, something that stimulates the growth hormone as a protein. So if you look at the qualifying criteria, his IGF-1 levels is within normal reference ranges. We don't have any abnormal IGF levels, but he has symptoms of not recovering and metabolic control issues with his insulin. So he was followed the sermorelin. He was taking sermorelin at 20 grams, 20 units per night, 5 times a week, and sermorelin 20 units subcutaneous, bedtime 5 nights a week. We did a follow-up questionnaire. This is 2 months on the peptide, and he still has a lot of symptoms, but if you look at his baseline, you can see some improvements. So this is the August one, this is October. See how nice these questionnaires are? Because sometimes patients don't remember what their symptoms were months ago. As soon as you pull something out like that and compare, you can see if there's any change. You can see there's still a lot of significant low testosterone symptoms, like the bottom hasn't really changed much. there's just been some changes in his muscle recovery, muscle aches and pains. His muscle aches and pains have changed a lot, but glucose, not much. It didn't make much difference with his glucose. His ferritin came down a little bit. That helped a little bit there. His lipid panel was not so bad. He doesn't have a thyroid condition, just to double check. His LDL is still showing like this metabolic pattern. Now here's the way you go. Well, let's check our testosterone. His testosterone was 165. So we like to see this above 400. So very, very low testosterone. This is with growth hormone peptides. Like it's not doing anything for him. Free testosterone was low. His luteinizing hormone was like on the low end of the reference range. If you look at the interquartile, maybe it's on the lower pattern. Sex hormone binding globulin was low. Sex hormone binding globulin is low if you have increased body fat, which he had. So that would explain that. But his free testosterones are low because he's not making testosterone. And PS, so those are abnormal. And then the key things to make sure that person is a candidate for testosterone therapy is they don't have a high PSA. His PSA, free PSA are all within normal limits. His IGF-1, IGF didn't become abnormal with taking sermorelin. They're still within the normal reference range. And his DHT, the most powerful androgen you want definitely in your system, is also low. So low total testosterone, low free testosterone, low DHT. Does everything right. There's not much we can do with the functional medicine approach, and even with peptides. So it's like, okay, maybe you should try testosterone. So he went on the testosterone replacement therapy, and before HRT, he had another testosterone level checked. They confirmed his testosterone was low, it's 249. And then this was the therapy. Testosterone cypionate, HCG, and then aromatase inhibitor were all what was given to him, which is basically the slide I showed you. They give HCG so you don't have gonadal atrophy. He's 49, he doesn't want to have gonadal atrophy, and injectable testosterone was given, and then an aromatase inhibitor. Then we also recommended, and he felt it was a good idea to take some natural aromatase inhibitors. So he was taking green tea extract and grapeseed extract and resveratrol, just because they're also just good for general health as well. And then follow-up test 1 month later, testosterone back to 493 within the normal reference range. No changes in his metabolic profile, anything abnormal. And basically, all his, like, if you look at this questionnaire now, it's almost mild or none symptoms. Like, within 1 month, something he's had for like 3 years changed. And almost like, oh man, we should have done this sooner. But what do you do? So this is, before and after. So that's like an example of that. Let me show you another couple cases really quick. This is a case of a 50-year-old female, 1 year post-menopause. Unpredictable bloating, dry skin. So she went through perimenopause. She's been through menopause now for a year, no menstrual cycle. She still has some skin inflammation. She still has joints in her pain, pain in her joints after exercise. She's got some gallbladder symptoms here. She's got some biotransformation symptoms here, maybe a little bit of slight blood sugar symptoms. And then we're like, at this point, you've been doing everything right. Let's check your red blood cell essential fatty acid profile. Here you can see, boom, completely deficient in alpha-linoleic acid. You have to get that from your diet. If you don't get it from your diet, you can't make it. And very, very low. And her DGLA was low as well. So you can see here, very low alpha-linoleic acid, low GLA. Put her on a treatment plan. Treatment plan was take things. She was low in alpha-linoleic acid, some GLA. We gave her some strategies to support her gallbladder because she's starting to get some symptoms of early gallstone issues, which was basically stop eating any kind of fried foods, reduce your sugar intake, drink some coffee, and she's already working out. And she also took some of the beetroot extract and taurine. She took a nutritional supplement that had these first 4 ingredients in there. And we had her stabilize her blood sugar levels. And then in 10 months, we did the repeat test. You can see her essential fatty acid profile is improved. Still not 100%, but the 2 essential fatty acids, the ones on top that you have to get from diet, alpha-linoleic acid, linoleic acid improved. These are still off, but she still may not be absorbing her fats that well. And if you look at her pre and post fatty acid profiles, you can see a huge difference between her levels pre and post test.
And then if you look at her initial metabolic assessment form, symptoms, you can see a lot of her gallbladder symptoms improved, her blood sugar level symptoms improved in the follow-up test 10 months later. So it's like a typical approach of how you might use fatty acids with menopause. Case number 5, really quick. This was a patient that non-responsive adrenal dysfunction, like chronically low hypoglycemia symptoms, exhausted all the time, depression, bad digestion, cannot sleep, fatigue after meals. And then another key point about this patient, on her dietary history, she's eating every few hours, high protein, healthy fats, nuts and seeds, every single adrenal supplement you can think of. No reason for her to have hypoglycemia symptoms. This is a primary adrenal issue. If you look at her adrenal profile, all her cortisol levels are low. Circadian rhythm is low. Look at her metabolic profile, no signs of any disease or pathology. And I've seen this many times before, and this is exactly what it was. It's an underlying adrenal autoimmunity. She has adrenal autoimmunity. So she's not going to be able to fix her adrenal glands with just stabilizing her blood sugar level. She has to now take on a full-blown adrenal autoimmune diet, nutrition, lifestyle approach. But be aware of that. When you guys see adrenal patients that aren't responding to anything and they're doing everything right, go ahead and screen for adrenal autoantibodies. And Addison's disease criteria doesn't get assessed in the healthcare system unless they use 70% or 80% of their adrenal glands. And then case number 6, really quick. This was a patient, postmenopausal, 2 years, no perimenopause. She had no symptoms through perimenopause. She was healthy. She did all the right things. She goes, hey, I just want to get my hormones checked. I don't know if I need to be on hormones. You know, I don't really want to if I don't have to. So here we are. Check her hormones. Estrone, estradiol, estriol, all her metabolites. Like everything is within totally normal limits. Like you're super healthy. You had no perimenopausal symptom transitions. You had healthy adrenal gland function going into it. You're postmenopausal now for a couple of years. You're totally maintaining your levels. You're on the lower end, but if you don't want to be on them, you're like within normal limits. You don't have any signs for increased risk for Alzheimer's disease and cardiovascular disease based on your hormones. You can check them again in the next year, and that's what she decided to do. So sometimes you just check and things are okay. She was able to really maintain her system there. And then last one here, case 7. This was a 51-year-old female, perimenopause with hot flashes and mood changes. She had multiple fibroid tumors. So even though she was having lots of symptoms of hot flashes and mood changes in perimenopause, she wasn't able to take any kind of HRT to control her. So she got massive fibroid tumors, multiple fibroid tumors that were there, and lots of symptoms of gallbladder issues, blood sugar symptoms, biotransformation issues. Blood tests show she started to creep up to insulin resistance. She didn't have any thyroid problems. Vitamin D levels were a little bit low. And no really checked for any kind of tumor markers, any changes in her immune system function with immunoglobulins and natural killer cell profile, nothing like that. And basically, we just put her on selective estrogen receptor modulators, put her on a product that had all 4 of them in there, placohoston, quiagenesin, diazine. I put her on a product that also had endothree-carbonyl DIM in there, and I put her on methyl donors. Had her decrease her fats, put her on some beetroot extract, taurine, vitamin C based supplement, support her biotransformation pathways with like a powder, taught her to stabilize her blood sugar levels, gave her some adaptogens, and we had to give her berberine to control her blood sugar symptoms, and within the 2nd month, completely symptom free, like totally fine. And now she's transitioning, no problems. So those are the applications of real life cases from the course materials that we went over, and you can see they can be very effective. They just take some time. A lot of it is diet, lifestyle. A lot of it is mechanism. Hormone deficiencies are definitely not a nutraceutical insufficiency.